Okay, we are going to now go to our panel. I think the way that I'm going to do this, I'm going to introduce the panel, which is here in Spartanburg, South Carolina, and I'm going to ask each panelist to take 2 minutes to say whatever they want to say, and then I have about 17 questions here that have been given to me, and then I'll ask the question, and whatever panelist would like to answer the question, please feel free to do so.
We have one panel member here in Columbia.
Okay, who is that panel member?
Dr. Turner.
Dr. Turner. All right, well, I'll tell you what. Let's start with Dr. Turner first. Dr. Turner, would you please introduce yourself?
Okay, this is Joe Turner, and you're specifically talking about treatments. I fall back on the thing about being informed. The most important thing you do is get all your information. Don't go to just a urologist. You need to go to talk to someone that's had something done before. You need to talk to the urologist. You need to talk to the radiation oncologist. You need to talk to the oncologist. Get a wide variety of options you have. If it's in your best interest to do active surveillance, that's fine. You just have to, again, it's all about informed decision and decision making. The other thing is you have to live with what you do. So if you choose something and you think that is right for you and your family and your timing, and as the gentleman said, if it's in his time in life, he did radiation, that was perfect for him. So it's just what you want to do. Again, prostate cancer is a slow growing. It doesn't have to be a decision made in a matter of 2 days. It's a decision that can be made over the course of 2 or 3 months and not impact your overall health.
Okay, thank you very much, Mr. Turner. We're back here in Spartanburg, and we'll start with Dr. Dan Freed.
My name is Dan Freed. I'm a radiation oncologist at Gibbs Cancer Center. I wanted to say I do agree very much with what Joe Turner just said about informed decision making. It's a very important process to go through. Again, prostate cancer exists on a really broad spectrum, from disease that probably never needs treatment to disease that can be life-threatening, and you need to really be informed and go through all of the variables with your physicians as to where your cancer may lie on that spectrum, because where it lies on that spectrum is very informative as far as what treatment options are reasonable for you. So important to do that. At Gibbs Cancer Center, we believe very strongly in multidisciplinary care, so we try to present all of the patient cases for a multidisciplinary conference so that they get the benefit of having their situation heard by radiation oncologists and medical oncologists and urologists and pathologists and radiologists and so forth, and all of the support staff, so that they get the benefit of a decision or recommendations from an entire team of medical personnel to help them in making their decision about what ultimately to do. So again, I think very important also to understand that prostate cancer by its very nature is a slow-moving process, and you do have time to make a well-informed decision.
I'm Drew Manito. I'm a physician here at Gibbs Cancer Center, also a radiation oncologist. So our panel is a little skewed toward radiation oncology, but Dr. Fried and I are both advocates for surgical therapy for patients who are good candidates for it. So I'm hoping we'll give you a balanced view today in the way we answer our questions. I reiterate again what Dr. Fried and Dr. Turner said. The other thing that I would always point out to men, that I think it's, as they're exploring their treatment options, it is a very good idea to talk to men who've been through treatment. But you have to be careful when you do that, because every man's situation is very unique. Their own the amount of disease, cancer that they have, their Gleason score, the size of their prostate, their urine function, their other health problems, that's different for each man, and what's a good solution for one man is not necessarily a good solution for another. So while it's good to speak to men about their experiences, you have to always keep in mind that your situation is unique, and the best decision for you is going to be individualized.
My name is Joe Dickey, and I'm a cancer survivor of 13 years. I am leader of the local Spartanburg US2 Prostate Cancer Support Group. And because I am a survivor, I believe in the screening. My cancer was diagnosed through screening. I was in a clinical trial. And because of the controversies surrounding screening, I think and feel very often that black men especially should be screened if someone in their families have had cancer, especially father, uncle, or brother. If they are screened, you have a baseline to see whether the cancer is going to elevate. And by this, all black men should be screened, particularly when they reach age 38 or 40. And if they are older men who are in their 70s, they need to be screened also, but they may not be treated. They may have active surveillance.
I guess you see these guys save the best for last. First, I just wanted to say thank you to everybody that showed up today. We have a good-looking group here in Spartanburg. My job here at the Cancer Center is to navigate men with prostate cancer. I go to a lot of the office visits with Dr. Manito and Dr. Freed. I've got wonderful physicians to work with, but I also go over to the urology center and to the medical oncology office. So I can help navigate patients to where they need to be. Insurance is an issue all over the state in getting resources that you need. So I try to plug the people into where they need to be. Education, we've talked about today, knowing your PSA, making sure that men are aware to ask their family physicians to get a PSA, know the results, monitoring those results. So I'm just happy that we've had a great group today all over the state, and more events like this is going to help to diagnose men and treat men sooner so we don't lose any men to prostate cancer.
Okay, we would like to thank our the people who are participating on the team today. I have a few questions that I'm going to ask, but before I start asking the question, I want to make one other comment to you too. Based on my experience in treating a lot of men with prostate cancer, shortly after they develop prostate cancer and even get the treatment, other medical issues arise. So don't be a victim of concentrating so much on your prostate cancer and letting your diabetes go out of control or your blood pressure go out of control or some of the other comorbidities that may coexist with prostate cancer. So make sure, and that's why it's important to have a medical home where you have a doctor who's looking at your other issues as well. Okay, now with that being said, the first question is, can you please define what a Gleason score is and how the score is used to determine the stage of cancer? Dr. Manito, you want to take that question? Yes, sir.
So the Gleason score is based, once you have a prostate biopsy and it's determined that there's cancer, the pathologist who reads it will assign it what's called the Gleason score. So the score is made up of two numbers that are added together. The two numbers are the Gleason grades, and each of those numbers ranges from 1 to 5. And then the first number is the most common pattern of cells that the pathologist sees when he looks under the microscope. So a normal prostate has a certain pattern of cells that are in a glandular pattern. As cancer develops, the cells start to look abnormal. The more aggressive the cancer is, the more abnormal the pattern of the cells appears. So the pathologist will give his opinion about the most common pattern he sees and then the second most common pattern he sees on the biopsy. And those two numbers are added together to give the Gleason score. The Gleason score theoretically can go anywhere from 2 to 10, but in practice we mainly see 6 to 10. In other words, it's very rare to see a Gleason grade below 3, the way pathologists read biopsies. So generally a Gleason score of 6 is considered a less aggressive cancer, and in fact in some men it may be a cancer that never progresses over time, over their lifetime. A Gleason score of 7 is considered intermediate. Gleason scores of 8, 9, and 10 are considered potentially more aggressive cancers that could spread beyond the prostate in some period of time. The way the Gleason score, with the newest staging system, the way the Gleason score plays into that is a man who has a Gleason score of 6 is generally a stage 1 patient. Gleason score of 7, 8, 9, or 10 can either be a stage 2A or 2B a cancer, depending on how far the prostate or the cancer has grown through the prostate. If it's grown outside the covering of the prostate, that automatically makes it a stage 3 cancer. And then a stage 4 cancer is cancer that has spread either to lymph nodes or to bone, usually to bones outside the prostate area.
Dr. Benito, you have to almost be a doctor to understand all this.
Okay. Okay.
Let me ask you this: is the Gleason score something? If I came into you, what information as a patient do
Sure.
I need to know about the Gleason score?
Okay, so knowing your Gleason score is very important. I think you should know that a Gleason score of 6 in some cases is a cancer that could be watched. A Gleason score of 7, there is more thought toward treating that, but it depends on your age and how long you're expected to live based on your other medical problems. Some Gleason score 7 cancers will be and can be just followed closely and not necessarily treated. Gleason scores of 8, 9, and 10, for the most part, unless the patient is very sick overall, otherwise are cancers that we're going to recommend some form of treatment on. So,
Thank you very
sure.
much. Dr. Freed, how is it determined if the cancer is confined within the prostate wall?
So there are a couple of things we can do to get a sense of that. First of all, we've talked already about the finger wave. Now, on digital rectal examination, doctors can get a sense sometimes of whether there is disease. That if there's very locally advanced disease, you can get a sense that the cancer has already gotten outside of the capsule of the prostate, or maybe that it's invaded the seminal vesicles. Usually, though, you don't have that much information from the digital rectal exam. Usually it's not so extreme that you can tell that. So we will also get a staging study. Usually people will get either a CT scan of the pelvis or an MRI scan of the pelvis. We actually prefer getting an MRI when you can, because you can actually see the different structures better on an MRI of the pelvis than you can on a CT scan of the pelvis. And sometimes we'll be able to see that there's actually gross disease getting outside of the capsule of the prostate on that, or that it's getting into the seminal vesicles. Either of those is somewhat worrisome. And when we talk about the T staging of prostate cancer, we talk about the T stands for tumor, so the tumor itself. When it gets out of the capsule, it's called a T3A. That bumps it into that T3 category. So T1, T2, T3, and T4. So going from the least worrisome to the most worrisome cancer. So the T3s are the ones where we see it getting out of the capsule of the prostate or invading the seminal vesicles. That's a T3B if it goes into the seminal vesicles.
One of the things that I have been told by men who get first diagnosed with prostate cancer is that the anxiety level is so high. When you start explaining all of this, they don't hear any of it. Can you make a few comments about how important it is to have your significant other with you so that they can hear what you may not hear?
That's actually a great point. You know, we really do encourage men to bring family members, bring your spouse, bring your sons and daughters, bring whomever is going to be able to help understand and remember what it is that is being discussed, and who will help to ask questions, because a lot of times men are kind of stunned, they're in shock a little bit by the diagnosis of cancer, and they don't think of those questions until they leave the doctor's office, and then they think of 10 different things, but by then it's too late really to get that information. So bringing family members and friends is very important. You don't want to have too many people because it gets a little bit too crowded in there, but having a spouse or even a few people with you really can help you quite a bit.
Very good. By the way, I don't want to leave out the panelists who are at other sites, so if you want to make a comment, please feel free to jump in. I'll just throw this next question out to anyone on the panel. What are the different types of treatment, and what are the risks of each? Now, I know we have radiation oncologists here, but I'm sure that you all can make a few comments about surgery and chemotherapy and et cetera. We'll start with Dr. Manito.
So in general, when a man is diagnosed with prostate cancer, really the first question is, should it be treated? As we've mentioned several times today, there are men who have cancers that are not likely to progress or cause them problems over their remaining lifespan, where they can be safely observed with what we call active surveillance. So that's really the first question. So if it is determined that treatment is necessary and the patient wishes to go through treatment, really the established treatments with a long track record are going to be forms of surgery and radiation. Surgery these days is, in most places, is generally offered with a robotic technique, which is a less invasive form of surgery that allows the patient, usually in our center, it's usually just an overnight stay in the hospital. The recovery time is quicker. The blood loss is less. There is, in terms of its ability to cure the cancer, it's not any better than the older technique where a larger incision was made with a prostatectomy, but as I said, the side effects of recovery time appear to be better. With surgery, anytime you go through a surgery, whether it's robotic or otherwise, there is a risk of infection, bleeding, blood clots after surgery. Some men who have heart disease may be at risk, although that's generally checked before they go through a major procedure. And then after surgery, there is a period in most men where they have loss of control of urination, where they have problems with leakage, we call stress incontinence. But in most men, that generally will improve over time. A few men may develop scar tissue in the urethra tube that carries urine from the bladder as a result of surgery that needs some treatment to it. As with radiation, the number one most common long-term side effect of surgery is how it affects the strength of erections, and there's a high risk of having some difficulty with that.
Dr. Freed, I'm an African-American male, and I present to you, you already told me that I have prostate cancer. Help me make sense out of the fact that you're telling me that I need to do active surveillance. I got cancer, but you don't want to do nothing about it. You just want to watch it? Tell me about that.
Sounds kind of crazy, doesn't it? So the point that I try to make to men is this, that prostate cancer is a very slow-moving process. Now, at one end of the spectrum, here, I got to use my hands, I'm sorry. All right, there we go. So if we think about, here's the spectrum of prostate cancer. On one end of that spectrum, we've got people who could live to be 150 years old, and they would never die of their prostate cancer. They would never have a symptom from their prostate cancer, and they would never even know they had prostate cancer if somebody hadn't checked their PSA, seen it was elevated, and then gone on to do a biopsy to find that they had cancer. Now, it's also true that prostate cancer is the second leading cause of cancer death in men in the United States. And so we can't just say, oh, nobody's going to need treatment for prostate cancer. So we've got to try to make sense of their disease. And typically what we try to do is to put their disease into a risk category: low-risk cancer, intermediate-risk cancer, or high-risk cancer. And that risk really speaks to the chance that this cancer is going to be life-limiting for them, or it's going to detract from their quality of life in some way. In other words, is this thing going to kill them? Is it going to go to spread somewhere to their bones and be painful for them? Is it going to invade something locally and make it so that they can't urinate normally? So the way we do that is by looking at three factors typically. One is the PSA. Number two is the T stage, as we talked about. That's what the examination of the prostate demonstrates. And number three is the Gleason score. As Dr. Manito told you, that's essentially the pathologist's view of how aggressive this thing looks under the microscope. So let's talk about how we stick people into their disease into those categories. So we look at the PSA. If the PSA is less than 10, typically we think of that as being in the low risk category. Between 10 and 20, that's intermediate risk. Up above 20, that's considered in the high risk category. The T stage, if you've got nothing that the doctor can feel as being abnormal on the physical examination of the prostate, or maybe you just got a little nodule, that's still considered in the low risk category. If it feels like there's an entire side of the prostate that's involved, that moves you up into the intermediate risk category. And if it feels like the whole thing is involved, or even like it's getting out of the prostate, that's in the high risk category. You got to be really careful about those. The last thing is the Gleason score. As Dr. Manito told you, 6s and below would be considered low risk, 7s would be intermediate risk, 8 through 10 would be considered high risk. Now, if you've got all 3 low risk factors, your PSA is less than 10, your T stage shows that there's really not anything particularly abnormal on the physical examination, and your Gleason score is in that low category, then you are potentially a good candidate to just watch this thing. When we say watch it, we mean really to monitor it very closely. We have a lot of data now coming out, especially from Canada, where they've been doing this for a number of years, and where they follow these men, they've followed them for 10 or more years now, and what they find is that the risk of dying of prostate cancer during that 10-year period ranges somewhere from 1 to 3%. Now, to put that in perspective, those same men have a 19 times higher risk of dying of something other than prostate cancer during that time. So if you select men properly, they can live their normal lifespan, monitoring very closely, and they may never need treatment. Now, just because you start on active surveillance doesn't mean that you never get treated. It turns out about a third of those men, as they're being monitored, they cross a threshold. Their PSA starts going up too fast, or they get a repeat biopsy that shows their Gleason score actually is worse than we thought that it was. That may trigger getting treatment. And so about a third of those men do wind up eventually getting treated for their cancer, but 2/3 of the men, they don't have to get treated for it. They live their normal life and they die of something else, and they never had to get the potential side effects of the treatment of the disease.
Thank you. Mr. Joe Dickey has a comment.
I certainly agree with Dr. Freed and respect him, and I trust my doctors. But as for me and the other men out there also who just didn't want to live with that disease, that cancer growing in them, so I opt to have my cancer removed. And I feel good about that. I think other men also, but I'm not saying that's what other men should do, but I felt that I need to have mine removed and not have something growing within me.
I'll make one comment. Let me make one comment. I think when I talk to people, I actually talk to them about being cancer phobic. If you're a person that's going to wake up every morning and think every finger pain that you have, every time you sneeze, it's your cancer, you probably need to get treated. If you're not cancer phobic, I think active surveillance in a low-risk disease is okay. But I see a lot of people, they just jump at anything. They want treatment, and they don't take time to take a deep breath and think about what they're doing. And so if you're going to be cancer phobic, though, if all you're going to think about is dying of your prostate cancer, by all means, you should get treated, whether it be radiation or surgery or cryotherapy or hormonal therapy or chemotherapy, whatever. But don't sit there and blame your whole life. Don't waste it blaming your cancer for something when you need to make a decision one way or the other.
Yeah, I agree with that comment completely. I think we do see that there are a lot of men who don't tolerate active surveillance well, and that's just it has to do with, as you say, a concern or a fear that their cancer is doing something, and they've got cancer in their body and they want it taken care of, and that's a completely rational fear. And so really, in addition, obviously, to having the right characteristics of the disease in order to be appropriate for active surveillance, you also have to have the right sort of psychology for it.
But there's also a cure for cancer phobia, and that's called education. I mean, if you spend time with men and you go over the information that we have, increasing amounts of information, and you do it maybe not on one visit but on several visits, they often become much more comfortable with the idea that their cancer may not need to be treated.
I think that's great.
Ms. Johnson. What are the barriers that you see in doing the kind of work that you do?
Education is probably going to be one of the first things. The patient who comes to the office visit a lot of times doesn't understand what the doctor said. So when he leaves or when they go home and they have the questions, they call me back. If I'm not able to answer the questions, I go to Dr. Manito or Dr. Freed or Dr. Hull and get the answers for the patients. I guess the second thing would be insurance, access to insurance. Transportation is another issue. We have a lot of patients that live in Cherokee County and Union County. So, and even here in Spartanburg, there's transportation issues to get patients back and forth to treatment. So those are probably the two biggest things that I work with.
All right, now I'm going to ask a question that most men want to know about is how is this going to affect my ability to get an erection? Which one of these modalities of treatment is going to allow me to have a reasonable sexual life after the cancer has been treated?
Yeah, that's a very very popular question that we get because it's foremost in many men's minds. Unfortunately, for men who need treatment, all the proven curative treatments for prostate cancer, whether it be surgery or forms of radiation, do have a significant risk of causing erectile dysfunction. Now, the risk kind of varies. Men who are older, men who are 65, 70 or above, men who already have some problems with the strength of their erections, they're definitely at higher risk of developing impotence after treatment, be it with surgery or radiation. Now, with surgery, if a man is planning to have surgery for his prostate cancer, the type of operation that he's going to have is key in terms of determining what's his risk of becoming impotent after surgery. So what's called nerve-sparing prostatectomy, if nerves are spared on both sides of the prostate, that does increase the chances of recovery of erections over time for a patient who has surgery. If they're spared on one side, if the surgeon is comfortable with that based on the amount of cancer that might be on one side of the prostate, that lowers their chance of recovery, but it doesn't eliminate it. If the surgeon determines that the nerves cannot be spared on either side, then the chance of recovering useful erections is very, very low. With forms of radiation, there are also external radiation or implanted radiation. There's also a risk of developing erectile dysfunction. It happens a little bit differently than with surgery. With surgery, usually it happens immediately, and then if nerves are spared, there's some recovery over time, over a period of months to years. With radiation, usually it's not immediate, but 2-3 years after radiation, we start to see the effects of radiation on the nerves and the blood vessels that control erections, and patients can see a drop-off in the strength of their erections. Now, there are treatments available for men who have erectile dysfunction, whether it be from surgery or radiation. The simplest treatments are the oral medications like Viagra, Cialis, and Levitra. If those don't work, there are some other methods that can certainly be effective. They're not quite as convenient as taking the pills, but there are options for men who have this problem.
Considering that's what I do for a living, about 60% of my patients are actually post-treatment for prostate cancer or bladder cancer patients. So if you're going to base your solely on whether you're going to have some leakage or whether you're going to have some erection problems, I'll tell you that my history has been that guys would much rather not leak than worry about their erections, because we can fix those erections. There's multiple treatments out there, and as you say, there's oral, there's multiple things out there. So the decision is still one that you have to talk to your provider about and come up with a good plan. If you already have problems, those problems are not going to go away just because you had surgery or radiation. The one thing I will say that is I think that you have to look at time frames. With surgery, I think a lot of times when guys are upset about it, they leak early and then they tend to gain control. Erections are a little bit different, so we do have some alternatives though for care. So don't limit, and I would say you just need to talk to them about what your options are at the time and then even afterwards very quickly. The quicker the treatment, the better it is.
I noticed the other day that Warren Buffett, who is in his 80s, had a PSA done. I found that kind of interesting that he had the test done when all of the guidelines say you shouldn't be getting tested after 70. I guess if I'm like Warren Buffett, I'm going to get my PSA checked. The next question that I'd like to ask is, if a man has been treated, can prostate cancer return? Dr. Freed?
Well, the short answer to that is yes. Depending on the disease itself and the way that it's been treated, the rate at which cancer returns is highly variable. But any modality of treatment, you do have the risk that the cancer will come back. And I think that unfortunately there have not been any good randomized trials, any very rigorous studies to look at different types of treatment to ask the question, is one of these treatment options better than another for prostate cancer patients and with certain disease characteristics. So, but as far as we can tell, surgery with a radical prostatectomy or radiation in various forms, including external beam radiation or prostate seeds or some variant thereof, tend to have pretty equivalent rates of controlling disease. But with any of them, there certainly is a risk that it could return.
Another question that I'm frequently asked, and I know is a problem, is prostate cancer that's found in a 40-year-old more aggressive than prostate cancer that's found in someone who's 60 years of age? And if it is, then how should that be attacked?
Yeah, that's a frequently asked question, but in fact, the information is that the aggressiveness of cancer does not go along with age. But we know the impact of prostate cancer on a man's life really depends on their life expectancy. In other words, a man who's 70 or 75 when he's diagnosed, he may only have a 10-year lifespan based on his age and his other medical conditions. So if he's treated for his cancer and it comes back, then it can usually be treated again, and he'll almost always die of something else anyway, unless it's an aggressive cancer. Now, for a 40-year-old, that's a much different story. His cancer will on average will not be more aggressive than a man who has it found when he's 70, but he has another 30, 40 years of lifespan left. So should his cancer come back 5 years after treatment, he's going to need more treatment, and over time he may break through that treatment. So his chance of dying of the prostate cancer, if the initial treatment's not successful, is higher. So it has bigger implications for a younger man. But in fact, the cells that are found in younger men compared to an older man are not generally more aggressive just because he's younger.
Any comments from any other members of the panel outside of Spartanburg regarding that issue? We have quite a few ladies in the audience. I presume that they're the spouses of the significant others. And the question is, should a man's spouse or partner be included in the treatment decisions? Kim, you want to take that?
I think it's very important that the wife be a part of the decision making. I've learned so much from our support group, and the ladies that are in our support group, when they marry their husband, it's for better or for worse. They're not leaving him because he has prostate cancer, but a lot of times a man will shut down. He doesn't want to hug or kiss or to be affectionate with his wife because he says he doesn't want to start something he can't finish. It's communication. And so that's one thing that we've talked about in our support group, is communication with each other. But making the decision whether it's going to be radiation or surgery, it is the patient's decision, but because they're a partner, their marriage, I think the woman has to have some input in helping the man to make the decision for his treatment, and then to meet other women that are going through the same thing with their husbands. So our support group here, I know that Johnny Payne in Greenville has a good support group, and women also attend that support group. So reaching out to people, learning as much as you can.
Mr. Dickey, you are a prostate cancer survivor. When you were diagnosed, what was the biggest fear that you had at the time that you were diagnosed?
At the time I was diagnosed with cancer, my biggest fear was perhaps I might die. And having received education and talking to my wife and talking to other doctors and reading material, I went to a doctor and found out that I had options, and my wife and I decided I would have the prostate cancer removed, the cancer removed. The only fear, it wasn't dealing with whether or not I could be intimate with my wife or not, because I could be intimate with her not by actual sex through sex. I could be intimate by embracing her, holding her, talking to her, telling her things, and she had accepted that. And that's the only thing I would say at this point, that men need to have their wives with them, men need to go through this together, and men need to have wives who are supportive of them at all times.
I was just online in preparation for this conference today, and one of the articles that I was very impressed with, and that kind of confirmed some of the things that I've seen, and that is African American men seem to make the decision to get treatment. He seems to take a longer period of time than white males. Do any of you have any insight into why that is the case?
I think it's a lack of trust in the system. I think it's all too long. I think it's there's been a discrepancy in the care that's been provided. There's that lack of trust of healthcare people in their own right because of race. I think there's no reason for that anymore, but it definitely exists. And if you're over 50 or 60, you remember clearly how it used to be. And so I think access to care now is much more open, but I can understand the lack of trust. So it takes a long time to develop that trust.
I wasn't going to approach it from that standpoint of trust. I think I would approach it that black men normally, some of the black men, are just fearful of coming to the doctor and learning that he has cancer. And if he has cancer, he feels that he's no longer able to do the things he would love to do. And that's why the delay is there for many of us. And they think, most men, black men think that it's probably best to stay away from the doctor rather than to go to the doctor and find out you have cancer. And they don't want to be in that area of worrying about that situation. So they need a lot of education and support and advocacy for the black man. And I think through the support group here and through this group here today, we can help to resolve some of those issues.
I agree with you. That's what health literacy is all about. Dr. Menino and Dr. Freed, here's a test here that I'm not familiar with. Are you familiar with the new Polaris genetic testing? And if so, how do you see this being used by clinicians in the near future to guide treatment decisions?
So Polaris is a relatively new test that is basically what they do is they take tissue from a biopsy. Usually it's been processed and embedded in paraffin. You can send that off, and they do an analysis of that, looking for RNA from 46 different genes. Now, 31 of those genes are genes that indicate that the cells are trying to actively grow. And then the other 15 of them are kind of housekeeping genes, just as a comparison. And basically what it's trying to do is give a score as to how aggressive that cancer looks when you look at that gene panel. In the preliminary studies that have looked at this, it seems to be a pretty good indicator of above and beyond the other indicators that we would typically use, like PSA and Gleason score and T-stage and all those other things, that it seems to add something to that in the predictive ability in asking the question. And they've done a few different studies. One of them was in a group of men who had their prostates removed, and it asked the question, if we do this gene panel on this group of men, does it help predict which of the men wound up recurring or having their prostate cancer come back? And it turns out it does have fairly good predictive ability in figuring that out. They also have done it in men who've had prostate biopsies and using the biopsy sample to ask that same question. And so now we're starting to think of that as maybe an additional piece of information that we can use to help men who've been diagnosed with prostate cancer decide what are the best treatment options for them. Particularly, what I've started using that for is in asking the question, is active surveillance a good idea for this man? You can see potentially if the cancer is significantly more aggressive than you might have thought. So I think it's going to be an important additional piece of information, but bear in mind it is just one of many different pieces of information that needs to be used in making a decision like that.
I think it has a ways to go before it's ready for routine use, because there are no studies looking at how interventions, if you decide a cancer is more aggressive based on that new test, about how certain interventions affect the outcome. So that's what we really need. So I think it needs to be more tests need to be done.
All right, now we're going to take some questions from the various sites. We'll start with Spartanburg. Yes, we'll take one question. We'll take one question first so that we can get around to all of the sites. Spartanburg. Yes, sir.
The biopsy procedure, can it affect the erection possibilities?
Can the biopsy procedure affect one's ability to have an erection after it's been done? Yes, sir.
Yeah, neither Dr. Fried or I are urologists, so we don't actually do biopsies. But from talking with Dr. Hull, I know there is a small percentage of patients who actually develop some erectile dysfunction immediately following the biopsy. You have to keep in mind it's a very small percentage, and for most men, if the doctor is recommending a biopsy, the benefit of finding out whether you have cancer, what type of cancer it is really going to outweigh the risk of a problem like that, because it is very low. But in rare circumstances, that can actually occur as a result of the biopsy. And I think in a lot of cases it is something that's reversible if it's just from the biopsy.
But now take a question from. Go ahead.
It's like 0.5%, I think, is what I saw. I think the one thing that you have to remember, that once you've had a biopsy, one thing that will cause is some hematospermia, some blood in your semen. So not just the erections, but you have to make sure that you're aware that if you have blood in your semen, it's normal after a biopsy.
Yeah. Any questions from Anderson? If no questions from Anderson, what about Florence? Any questions from the Florence site? Any questions from Columbia? Wow, we're doing a great job here. No questions. Any questions from Charleston? I want to make this comment. This is something that I became aware of from reading an article, and that is men who have prostatectomies. It has been reported that a small segment of those men complain of a decrease in the length of their penis. I don't know whether you all are aware of that or not, but can you make a few comments about that?
So we do hear about that some, and so if you think about what the prostatectomy is doing, here, wait a minute, I gotta use my hands again. All right. If here's your prostate, and above it sits the bladder, and the urethra runs right through the middle of it and out the penis, what you're doing essentially is cutting at the top of the prostate between the prostate base and the bladder base, and you're cutting down here at the pelvic floor musculature, and you remove that. Well, then you got to rejoin those ends of the urethra. One of the things you do is you pull down on the bladder neck, and that's the majority of what happens with that. But you're also pulling back on the stump of the urethra from the other end, and you can pull back on that some and actually get sometimes there is some shortening of the penis because of that.
And also based on
1 centimeter.
Just one moment.
if one is obese, then that has a tendency to cause it to look as if it's small also. And if you're not using it, it has a tendency to shrink.
Well, you may laugh, but I can tell you that these are questions that black men come in asking me all the time. Do you want him
1
to
centimeter.
repeat that? Can you reverse that? No.
Well, it's usually 1 centimeter of length lost is kind of what I tell guys. There's some studies out there saying a vacuum erection device use early on not only helps rehabilitate the penis as far as function, but it has been shown to increase girth and length somewhat. Whether I believe that fully, I think it does help with girth. I think the other thing is if you're sexually inactive for a while, you have atrophy. And I do agree with the fat comment that if you're fat, yeah, it just kind of hides from you for a while.
Yeah. One of the other things that I certainly would encourage. This is just not due for prostate cancer, but this is due for any cancer, and that is if you increase your fitness level, it helps you better able to deal with the treatment, and it improves your chances of regaining what you may have lost during the procedure. So that's another reason to do physical fitness on a regular basis. Any other?
I have a question.
Yes.
I have a question from Greenville. This is Johnny Payne.
Yes,
we're
Johnny.
all aware. Yes, we're all aware that if you have a radical prostatectomy, then the result of that is dry ejaculations. Do you also have a dry ejaculation if you have the seed implants or external beam radiation? Are dry ejaculations a result of that as well?
With either form of radiation treatment, you certainly can see a decrease, or in some cases, a complete lack of ejaculation fluid. So it varies. Most men, in my experience, do see a decrease, but not a total loss of ejaculate. But some have a total loss. So it's a side effect of radiotherapy, as it is with surgery, can be with radiation as well.
Okay, thank you.
One of the questions that I'd like to ask, I know that robotic surgery is now the order of the day. Are the studies showing that robotic surgery is better than conventional prostatectomies? Dr. Freed?
So there have been a number of studies looking at this question, and the simple answer is not really. There's not any particular difference between the two. Certainly there is a more rapid recovery from a robotic prostatectomy than from an open prostatectomy, but as far as its ability to get rid of cancer, there's not an appreciable difference between the two. Either one is quite effective at getting rid of cancer. One's not better than the other.
Okay, we are just about to wind this up, but we are going to go to our next segment, which is